Okay, so we're finally up to block 4. I should be able to finish up the rest of this right now and get that going too. So I think I'm up to question number 38. So we'll do 1 to 25 in this video, and then I'll come back and do one last video for numbers 26 to 50 of block 4. Now for my specific test, the question orders are different for everyone, right? So the order I have it in, blocks 1 and 2 were real nice. I felt like there was nothing crazy there. Block 3 is where the NBME trash alert really started going off a lot. There were a lot of questions that were either misconstructed or the answer choices were just not exactly what you would expect off of something like UWorld or Step 1. And then, of course, there were some questions where you just find yourself asking, like, why would I know this? So it's a really annoying thing. Okay, Joseph, 3 days counting, man. Good luck. Good luck. I wish you the best with that. Just make sure you're ready. Make sure you're ready. You've never been annoying. You'll be fine. You're gonna do great. I wish you the best of luck. All right, so let's look at this questions 1 to 25. Get this in there, and then I'm gonna take a little break. I'll come back and I'll finish up the rest of it. Probably today too, depending on how hungry and out of breath I feel, or how dehydrated I feel. Let me combine this so it's a little bigger that way. Okay. As usual, again, just remember, I sell everything that I use here, so feel free to reach out to me at any time. The page numbers are usually a reference to First Aid 2019, and if there's 2 page references, then the second number is a reference to my own PDF, which has extra pages in it, so the numbers don't match up. Alright, right here. So, number 1, a 15-year-old girl with cystic fibrosis. So this is another cystic fibrosis question in the same NBME again. Has a mutation in the CFTR gene, which results in deletion of phenylalanine 508. This mutation does not prevent synthesis of CFTR protein, but does prevent it from folding properly, which is pretty typical. The improperly folded CFTR protein will accumulate in which of the following cellular compartments? And oftentimes when you read a question like this, the immediate thought in your mind might be the cytosol, which is why they put that as the answer choice first. So A says cytosol, but you should remember that the misfolded protein gets retained in the ER, right? So endoplasmic reticulum was the answer here. This is actually in first aid. Cystic fibrosis is extremely high yield, so you do obviously need to know everything inside and out about it. So they tell you here, most commonly it's a misfolded protein and it gets retained in the rough endoplasmic reticulum. Also, there's now treatments, right? So if you haven't moved on from First Aid 2018, then First Aid 2019 started mentioning treatments in there. So they had a combination of lumacaftor, which corrects the misfolded protein and improves its transport to the cell surface, and ivacaftor, which actually opens chloride channels so that you can fix that chloride issue, right? So I made up this thing to remember it. Lumacaftor, think of illuminate your vision by opening your eyes, hence it opens the channel by correcting them. And ivacaftor, think of IV infusion of chlorine or something like that, so that you can remember that ivacaftor is fixing the chloride channels. Right, so those are relatively new. I have yet to see a question where those medications get tested on per se, but definitely worth knowing because it can come up. And of course, your step 1 is running out of things to ask, so got to make sure you're on par with everything, because they don't want to keep asking the same questions over and over, so they like picking on new things. This question was okay, it wasn't so bad. Again, they picked on something that you might not be so confident on. So a 22-year-old woman comes to the physician for a follow-up examination. She has a 5-year history of migraines. She began taking an oral contraceptive 6 months ago, but she stopped the contraceptive 1 month ago because it resulted in increased frequency and severity of her migraines. The headaches have since improved. She does not want to try other forms of hormonal birth control, and she asks about the most effective alternative. It is most appropriate for the physician to recommend which of the following contraceptive methods for this patient. So if you're looking to go into OBGYN, it is very likely that you'll get a patient just like this. Someone with chronic migraines who started taking hormonal oral contraceptives and then their migraines worsened. It could be any other issue. They might have started gaining weight, whatever it might be. For some reason, they don't want to do it. They come back. What do you do next? You offer to give them IUDs. That is all you do as a doctor for contraceptive methods. It's either going to be the pill or an IUD. Everything else that's here as an S choice is not really something that requires a doctor. So I wrote, overall, the only forms of contraception you'll ever give someone as a gynecologist are either oral contraceptives or IUDs. The other things don't require a doctor and are found over the counter, like a contraceptive sponge, a diaphragm, and a rhythm method are all really unreal answers because those are not things that you have to do anything about as a doctor. And those are the things I put pictures of one after the other. So from left to right, that's a contraceptive sponge on the far left. Right, you can see it kind of closes the entrance into the uterus, so it's blocking the cervix. This one here is a diaphragm. It's pretty similar to it, and it also has spermicide in it, so it's also blocking entrance into the cervix. And then this is based off of what many people use, the rhythm method, right? So watching when you're infertile, right, and then when you are fertile, and again when you're infertile. This period of red, green, and purple, these are used for both purposes, either for getting pregnant or for not getting pregnant, right? So you know your fertile period, then you really try to have sex every day on these days to achieve getting pregnant. Whereas if you're trying to not get pregnant, then you try to have sex on the green days here. Those are the days that are most likely safe days to have sex, okay? And it's based off of your first day of the menstrual cycle. So this is the day menstruation started, right? Then you're infertile at the point, but you're also bleeding at the point. Is it safe to have sex? Sure it is. You know, is it going to be as pleasing and as good? Well, that's really up to each individual on their own. You know, some people don't prefer having sex when the female is menstruating, but that's the red period right there. So that's that 1 week of menstruation. After that, right after menstruation has finished, she has this fertility period, right? This is the period where at any point the next egg can be released and she is fertile. And then after 2 weeks of that, so you can see from 8 to 14, then 14 to about 19 to 20, she's going to become infertile. Now the endometrium is going to start getting ready to slow off again for the next menstrual cycle. So she's supposedly infertile. Now, of course, none of these are exactly extremely successful. The success rates are different for all of them. Some of them have a success rate of up to 80 to 90. But of course, oral contraceptives and IUDs have the highest, even they're not 100%, but they have the highest chances of working out in terms of being a contraceptive. For currently the second year, I actually want to ask which textbooks. Yeah, sure. You can shoot me an email anytime, sure. So I don't take up time in this video about other things. But you can feel free to email me at any time. Okay, so that's it for number 2. Nothing crazy. Pretty well written question. Oh, and the spermicidal foam. That is also something you can just buy over the counter. All of these are things you can get over the counter and use by yourself. So those wouldn't require a doctor. This was cool. This was a question about the coronavirus. Right? So that's really, really appropriate. An investigator is studying a new virus isolated from a 4-year-old girl with fever and cough. Initial experiments showed that the virus forms plaques on cultured human laryngeal cells, but rapidly loses its ability to form plaques when dried or exposed to a pH of 5.0, which is below neutral, so a little acidic. This infectious agent is most likely similar to which of the following viruses? So the virus they're describing is some other virus that is similar to one of these viruses for a specific reason, and that reason is the fact that drying it, which means putting it in heat or putting it in acidity, kind of makes it lose its viral factor. So you know the virus must be enveloped because it does not hold up to acidity or being dried, and that's all they were really pointing out. And then they wanted to know which one of these is enveloped, and the only one here that's enveloped is the coronavirus. The other ones are not. So you can also answer such a question just by using the logic aspect of which one of these is least like the other. So Coxsackie, Epstein-Barr virus, norovirus, and rotavirus are not enveloped viruses, but the coronavirus is. Right? If you've done Sketchy Micro, then you would remember from the coronavirus image, which is pretty significant to revisit. So the coronavirus image was, let's see right here, it's in the sun, right? So this one, it's in the sun, it's a sunny day, and the sun looks like a plus sign, so that's because it's a positive virus, right? It's a positive RNA virus. Oh, right here, right? Coronavirus, positive RNA virus. Helical, so that's, you have the helical hills, helical everything, right? And he's wearing a robe. That's to depict that it is enveloped. right? And yeah, that's basically all the notes for it. So SARS and the common cold, and then now we have COVID-19 in here as well. So that might get published later on, maybe in first day 2021. You'll see COVID-19 over here as well. Okay, so that's all this question was about. Nothing crazy there either. Good little question to just check on your knowledge and grasp of characteristics of different viruses. But not exactly a question directly about coronavirus, but the coronavirus was the answer. An otherwise healthy 35-year-old man sustains a fracture of the left pelvis in a motor vehicle collision. 3-week period of bed rest for this patient is most likely to cause which of the following physiologic changes? Now, this question was really interesting because I have never seen a question about this topic in this way. I didn't know after, usually when at this point when you're done with like most of your studying and you're perfectly ready for step one, or as for me, I finished step one. But even like, I'm still doing all these videos, right? So it's almost like I'm still studying for step one and I know everything so well. Usually at this point when I read a question, I'll have a good idea of what the answer should be. I had no idea when I read this question. I didn't know what would be, which one of these would be changing like this. So I read all the answer choices, decreased blood volume. I was like, why would he have a lower blood volume? That didn't make sense to me. Then I read decreased plasma sodium concentration. That one I said no to because there's no reason for his sodium concentration to change. Increased plasma aldosterone concentration for the same reason. That didn't make sense either. Increased plasma volume. That one to me rang a bell, and I was like, okay, maybe he's gonna have edema from just sitting for so long or just laying in bed for so long. So I didn't knock off D. And then E, increased sympathetic nerve activity. Sympathetic activity occurs with fight or flight responses. So sympathetic is not a resting thing, and he's resting. So I knocked off E. So I was really just between A or D. And then I sat back and I thought more about it, and I was like, I don't see any reason his plasma volume would increase either. So it's more likely it's going to be his blood volume would decrease for some reason. Maybe he's not going to make much blood because he's so inactive. He doesn't need more blood circulation, something like that. And I chose A. Then I did more of my research to find out what the correct explanation is, and this is what I found. Being in bed rest changes the effects of gravity on your body because you go from an upright plane to a horizontal plane. Bed rest over 24 hours eventually causes a shift of fluid away from the legs towards the abdomen, thorax, and head. So that makes sense, right? Because now you're always horizontal, so the blood is evenly spread out and it's not going to stay in the legs. This increases venous return to the heart and elevates intracardial pressure. The full in-depth conversation is in this link, so I'll put this in the chat right now. And it's a very well-written document. So this increased venous return stretches out the right atrium and releases atrial natriuretic peptide, ANP, which is a diuretic that induces urine output and decreases the blood volume. Normally, the drop in blood volume would be detected by the reduced stretch in the baroreceptors of the aortic and carotid sinus. The aortic arch and the carotid sinus have baroreceptors. They would notice the reduced stretch, and then they would induce ADH release, and the ADH would counter that and fix it, right? Reducing urine output and increasing blood volume. So you would have normal blood volume maintained. However, in supine individuals, people who are in bed rest, the increased venous return also increases stretch of the aortic and carotid sinus baroreceptors, reducing ADH release. This further increases the volume reduction. So this is a really interesting physiological thing about the cardiovascular system. So I liked it. I liked the question. I liked the explanation more than the question. The question was kind of awkward to me. So in summary, supine individuals have increased pressure in the right atrium and on their baroreceptors. The right atrium makes more AMP, and the baroreceptors end up reducing the amount of ADH they make because of the increased stretch on it. Mobile individuals would have a reduced stretch of the baroreceptors because blood would be in their legs, not up here, increasing ADH and balancing the volume loss. Okay, so by being mobile, you keep your blood volume stable. But by becoming supine, your blood volume starts to decrease. And to me, my own logic was not equally, but relatively good enough as well, right? My own explanation answering this question was just that if you're so immobile, you don't really need much blood, you don't need much oxygen, you don't need much anything. You're just resting in bed, so blood volume going down isn't going to be the worst thing for them. And That led me to the same correct answer as well. So as long as you can come up with something that leads you to the correct answer, that's all that really matters, right? Get good enough with the physiology of different things so that you can get the correct answer, because you don't need to explain your correct answer in the test. This was probably the worst question I have ever seen in any NBME. Right? So the NBME trash alert was strong with this question. 23-year-old primi-gravid woman, 22 weeks gestation, is brought to the emergency department at a small rural hospital by her husband because of intermittent bleeding during the past week. The patient woke up this morning with a copious amount of vaginal bleeding and severe pelvic pain. She has noticed no fetal movements for the past 24 hours. Her pulse is 120 per minute, blood pressure is pretty low. It looks like she might be going into septic shock, DIC, something along those lines might be coming, and maybe the fetus is actually dead. Her obstetrician is a woman whose practice is 2 hours away. The patient is dressed in a burqa and explains that she is a conservative Muslim. She does not want to be examined by a male physician. However, the only physician available in the emergency department is a man. Now, this is a very unlikely situation. We have enough female doctors in the world and in almost every part of America that there will be some female physician available, even if she's not a gynecologist or an obstetrician. As long as it's a female physician, the female physician can come and examine it. We're all good at doing all the different things, right? That's the reason we have rotations. If I become a cardiologist, it does not mean that I can't go do the job of a gastroenterologist. Maybe not as optimally, but I'll still understand the situation and be able to convey it to another doctor. Either way, assume this is some kind of state where something like this is happening. Which of the following is the most appropriate action by the physician? Now, with ethics questions, you always want to make sure you don't overthink, right? But with appropriate action questions, which are pretty high yield, appropriate action questions, you want to make sure you don't say something that might offend someone, you don't do something that might be against someone's wishes, right? And you treat the patient, like there's someone that has a gun to your head, or someone that, you controls how your life is going to be, has the ability to take your license away, basically, right? So you ask the patient if she would allow the examination if her husband is present at all times. Maybe. Have a female nurse examine the patient and report her findings to the physician. That makes good sense. Obtain an emergency court order to examine the patient. No, you almost never do the court order thing, right? That's not even going to be quick enough. Emergency court order? No, that's not happening. At the amount of time the court order will take, she might as well just go to the 2-hour away obstetrician. That'll probably be quicker. Request the hospital chaplain speak with the patient. Okay, a chaplain would be there to come tell her to stop being conservative, and you can't do that to someone, right? You can't tell someone to practice their religion differently. That's not going to work. Transport the patient to a major medical facility 2 hours away where she can be examined by a female obstetrician. That also makes some level of sense, although because she's bleeding so much, she might become in even a much worse condition by the time she gets there. Of course, at the end of the day, though, it is their decision if they decided they want to go to the 2 hours away anyway, so they can make that decision. The correct answer here was A, and I find A to be a very offensive question to ask. Okay, that is a question that someone can become very offended with. I chose B for this question. If I was the male physician that someone told me, a Muslim woman in a burqa told me that she's conservative and she doesn't want to be examined by a man, and I'm Muslim, so I understand that, I would not be like, yo, how about if your husband's here? Can I touch you down there if your husband is there? No, that's stupid. That is the most ridiculous question he can ever ask. A Muslim woman's conservatism doesn't really come off of whether or not her husband approves of something. She's doing it because it's her religion and it's between her and her God. It has nothing to do with the presence of her husband or the permission of her husband. It's almost like this question was kind of mocking the religion and its practices in a way. So asking A would not be the correct thing to do. But if there is a female nurse around, now nurses aren't illiterate idiots or something. They're better than many students who are they're better than medical students who are doing rotations. They are very adept at everything. They're practically doctors without an MD for the most part. I would totally ask a female nurse, hey, check her out, do the examination, let me know what you find out, and then based off of that, then I could evaluate, okay, listen, your wife is doing really, really bad right now. You need to let me know what you want to do. Or it looks like your wife is going to be okay. She might be able to take the 2-hour trip. You guys should head over there as quick as you can. Something like that. right? So asking the patient if she would allow the examination if her husband is present is just wrong, right? Um, Again, but this is coming from the fact that I'm also Muslim, so I get it. But people that don't get it, or people who might look down on the practices of the religion, or people who just feel like maybe this is how it works, to them A might be the correct answer. And again, this question was just really offensive in general. At the same time, I showed this question to a couple people that I know that are not Muslim, either Hispanic. I showed it to two of my Hispanic friends, and then I showed it to two of my friends who are one is Chinese and the other one was black. So I showed it to four different people, and they all chose A. They all felt like A made sense. So I could see how the cultural clash and the lack of understanding of how the religion works allows A to be the correct answer, but to a Muslim person, A would never be the correct answer. Right? So this was just stupid. This was so unnecessarily dumb, but A was the correct answer. Generally speaking, if this wasn't about Islam or Muslim people or anything like that, asking something is okay, right? Asking, hey, how do you feel about doing this, is okay. That's perfectly safe in terms of ethics, because that gives the patient a chance to evaluate an option, right? Whether she wants that in this manner or not. But again, B is perfectly fine too. Okay, so I'm going to have a female nurse check you out. There's nothing wrong with that. If someone's going to say, oh, female nurses are not capable enough, that is completely wrong. The female nurses and nurses in general know everything a doctor knows. Okay, as far as practicing is concerned, they might even know more than most doctors know, because they're the ones that are actually dealing with the patients and taking care of them and making all their notes and doing everything in the hospital. So really dumb question, not worth the time I just gave it in explaining it, but it was just really annoying. This was annoying just because of the answer choice they picked. So, 37-year-old man who is a farm worker comes to the emergency department because of a 12-hour history of severe pain in his abdomen and legs and painful spasms of his jaw. Physical exam shows marked spasms of the masseter and abdominal musculature. During the examination, a loud noise in the examination room triggers painful spasms and respiratory compromise requiring intubation. Administration of antitoxin prevents further symptoms, but the patient continues to require sedation and ventilatory support for the next 3 weeks. This patient most likely has a syndrome that involves binding of a toxin to which one of the following? So you look at all your answer choices and you should be able to knock everything out, bringing you to E, and then you lock in E. Right, so this has nothing to do with acetylcholinesterase, although it makes sense why they put that as a first answer choice. Because the question started with the farmer presenting with weird symptoms, and depending on how much you've studied it and how much you've mastered it, you might think this was something related to cholinergic symptoms and organophosphate poisoning, but this isn't that. Right? This is not about organophosphate poisoning at all, where acetylcholinesterase would still not be the correct answer anyway, but still. N-acetyl-nuraminic acid, if you don't know what that is, you can leave that there, but then you keep going. Calmodulin has to do with smooth muscle, that has nothing to do with it. Monoamine oxidase should make you think of MAO inhibitors, and that's irrelevant here. Ubiquitin, again, that's irrelevant here. Ubiquitin is more for tagging proteins or amino acids to be trashed. Irrelevant. So synaptobrevin was really the only answer choice left that you might have never heard of, but it's actually one of the snare proteins. Right, so it's very clear from the symptoms they gave you that this patient has tetanus. Right, this patient might have stepped on a nail or something somewhere and got tetanus. So from there on, you know that this is Clostridia, and Clostridia are related to snare proteins. And synaptobrevin is actually one of the 3 things that make snare proteins. Right, so syntaxin, SNAP25, and synaptobrevin. Those are the 3 things that make up snare protein. This answer choice should have really just been snare protein. We are not required to know every single tiny thing, right? As a doctor, it's not going to be required by step 1. It's not required by UWorld, right? But NBME picks on things you might have never heard of because they probably think they're really cool for even having discovered synaptobrevin, right? In this image, they probably found it when they looked up snare proteins, and they're like, let's remove snare protein as a choice and put synaptobrevin. They'll never think that's the correct answer. And that's something that UWorld is very, very popular for. So even when I first read this question, I was like, this thing looks like it might be the correct answer, because that's kind of how not URL, NBME. That's how NBME works. A lot of times and I'll show you more as we keep going right now too. A lot of times NBME questions have an answer choice that you might have never heard of, and that's the correct answer, because that's what they're doing. They're putting answer choices that are so far-fetched that you will either immediately write it off or just think there's no way that's the correct answer because you've never heard of it. This was a good question also. 43-year-old woman comes to the physician because of a 1-week history of abdominal pain, nausea, vomiting, itching, and fatigue. Okay, physical exam shows scleral icterus and right upper quadrant abdominal tenderness. There is no rash. Abdominal ultrasonography shows a large stone in the common bile duct. Complete blood count with differential shows no abnormalities. Serum total bilirubin concentration is very high. The serum concentration of which of the following is most likely to be very high too? So if total bilirubin is super high, that means either direct or unconjugated bilirubin is going to be very high. And that's why they have answer choice F there, which I'm surprised they put it there and not as A. This is a liver pathology question, and you want to make sure you understand all your liver pathologies extremely well, how it works, where the bile goes, what it all causes, etc., etc. This patient has gallstones, possibly due to biliary stasis, right? So some gallstone came out and got lodged in the common bile duct. This has caused damage to the biliary tract because the stone must be lodged in the common bile duct, which is what they told you. Now, bile will back up the common hepatic duct and cause injury to the epithelial lining of the biliary tract. Its leakage, the leakage of bile into the bloodstream, is what's inducing the itching that she has. Okay? Any damage to the biliary tract epithelia leads to a leakage of alkaline phosphatase. Okay, and that was the correct answer, C. So, in case you did know alkaline phosphatase is the correct answer, they put acid phosphatase as the answer for A. Okay, so they can confuse you. It's just a psychology thing. Which is significant for cholestasis and its consequences like biliary obstruction. So biliary obstruction leads to an elevation of alkaline phosphatase. AST and LLT would be elevated in hepatocyte injury, which is not the case here. Right? Alcohol, scotch, and tonic for the alcoholic stuff. ALT for the non-alcoholic stuff. Acid phosphatase is just a phosphatase. It removes phosphates off of other molecules. It's irrelevant to liver damage per se. LDH, right, lactate dehydrogenase, converts pyruvate to lactate and is clinically significant for hemolysis. Anything that causes hemolysis would have an elevation in LDH. Bilirubin conjugation occurs in hepatocytes and they are functional, so you would not have an elevation of unconjugated bilirubin. The only time you get unconjugated bilirubinemia is when you cannot conjugate the bilirubin, maybe because the enzyme isn't working, and that's not the case here. So if anything, she would have an elevation of conjugated bilirubin, which is why her total bilirubin is high. Okay, so the correct answer here was just alkaline phosphatase. You want to make sure you understand all of that stuff, Charcot's triad, Reynolds pentad. There are some videos about this in osmosis, some of which are free, some of which require you to sign up and stuff like that. Let me go to the 427 to show you something real quick. So, no, 427. Why isn't it working? Okay. So right here are all your serum markers of liver pathology. Right? Our question was about alkaline phosphatase. You want to make sure you know what the normal ranges are. They're not in first aid. So get those normal ranges in. Alkaline phosphatase is elevated in cholestasis, right? Like biliary obstruction. So that's what our question is about. However, alk phos is also elevated in bone disease. Right? So you always have to use GGT, which is more related to liver pathology. Right? So GGT would be elevated only in liver issues, various liver and biliary diseases, but not in bone disease. Okay? Even with alcohol use. So GGTP, gamma glutamyl transpeptidase, is a very specific indicator of liver problems. And that could have been an answer choice too. Number 8. This was a perfectly easy, fine question, but the question was designed in such a way that it could intimidate you. So you always want to practice understanding the fact that you don't need to get intimidated. Serum cholesterol concentrations are measured as part of a community study. The means and standard deviations are given for women by age group. Right? So there's ages 45 to 49, and the mean is 229 plus or minus 47 for the standard deviation, and so on for the other groups. Assuming serum cholesterol concentration follows a normal Gaussian distribution, which of the following is the probability that a woman between ages 50 to 54 has a serum cholesterol greater than 296? Okay, so all we care about is this age group, right? And they want to know the greater than 296. So one standard deviation from 246 plus 50 brings it to 296. They want to know more than that, so that would be the 2 and 3 standard deviations away. That would be anything after that, right? Now you need to remember your percentages, and then you're good to go from the Gaussian curve. That Gaussian curve you can put on your cheat sheet if you want, or you can just memorize depending on how good you are at that. This is the Gaussian curve right here. Right now our question is about this half, this much right here, right? Because we already saw one standard deviation fell within what they wanted. The rest of it is everyone more than 296. So this entire portion here. And how much is that? What is the 2 and then the 3 and then this tiny portion here? All those percentages are things you should really have a good grasp on. First stage shows you the 68, 95, 99.7. Okay, but this one here, this is 34. Okay, so that's one standard deviation is 34% here, 34% on the other side. All right, this here, number 2, this is just 13%. Okay, that's the 13% alone. So if you add both of them, that's 34 plus 13 gives you 2 standard deviations. And then this one here is just about 2%, like 2.5 or something. So you can estimate those things, and you need to memorize those numbers. So you can put them on your standard deviation on your cheat sheet if you do want to. Right, so our guy would be the 16% right here. Right, that's the correct answer, D. The others do not make sense. So anything above 2 standard deviations is usually going to be people, above 1 standard deviation are going to be people that are in the extremes of a Gaussian curve. So it should be a smaller percentage. So you could immediately knock out 95%. Now the 1 and 2.5 didn't make sense at all because those are too small. That's going to be the extreme, the far, far extreme. More than 3 standard deviations or more than 2 standard deviations. So those didn't make sense either. But again, you don't want to answer such a question solely based off of what makes sense. You should be able to actually numerically solve it. Right? So this wasn't so bad at all. This was another annoying question. I was really hoping I wouldn't have to call this one NBME trash, but I got this wrong. And on top of that, it's not just that I got it wrong. The answer itself is not very reliable. So a 20-year-old woman with asthma comes to the physician because of exacerbation of her symptoms during the past 3 months. She says, I'm able to control my asthma attacks using my inhaler, but it concerns me that these attacks are happening so often lately. She's a college student who has always carried a heavy course load. She says that it's sometimes stressful taking so many classes at one time, but she enjoys the challenge. Fine. 3 months ago, though, this is where something new happened. She moved from the campus dormitory into an off-campus apartment, which is usually cheaper, with some friends. She tells the physician, I'm really happy that I was able to bring my pet poodle to live in the apartment. So that's not something new. The poodle was always there too. Sometimes I have disagreements with my roommates because they never seem to want to clean up after themselves, and one of them kind of annoys me by smoking in the apartment. What a douchebag. Also, I think he keeps the apartment too warm. But all in all, I'm really happy to be there. Physical exam shows no abnormalities. It is most appropriate for the physician to advise the patient to do which of the following. Now, for understanding purposes, college dorms are very expensive, but right outside the college dorm areas and right off of college campus, there are many housing facilities that are often much cheaper. Okay, so she's obviously really happy to move into something that might be actually half the price, especially living with other roommates. They can all split the cost. When someone's asthma exacerbations start to get worse over a certain small period of time, acutely, you want to see what changed. Her course load didn't change, right? Her stress from school is still the same. Her dog has always been there, so that's still the same. It seems that the only thing that might have changed was this new house where there's someone that smokes, and that's bad for asthma. The temperature seems to be warmer, and that's okay for asthma, but maybe it affects her. And it's a little dirtier than usual, which can also be bad for asthma, right? So now what can you, as a doctor, right? It is most appropriate for the physician to advise the patient to do what? What can I do as a doctor? Ask the roommate not to smoke in the apartment. As a physician, I have no access to the roommate, nor can I tell her to go control her roommate. If her roommate is smoking in there and she's obviously been annoyed by it, she must have already complained about it. He's not going to stop because he has every right to smoke in there. He's also paying the same rent that she is. So that's out of the question. But that's actually the correct answer, which is so stupid. Begin treatment with daily prednisone. Irrelevant. Decrease her course load until the exacerbations decline. No, her course load was worse before too, so that's nothing new. So it's not the course load that's causing it. Get an air cleaner for the apartment. hey, that's something she can do by herself. Doesn't bother anyone. There are amazing air purifiers out there right now. That might actually help her. Let's recommend that. That should have been the correct answer, but the answer here is actually A. And that's just dumb. There's no way any physician in their right mind would be like, you know what, you should tell your roommate to stop smoking in there, go have a chat with him. That's not going to happen. What if she's intimidated to go talk to her roommate? And how do I not know if she hasn't already talked to her roommate? And on top of that, if you live with someone else and you're both paying the same rent, you have every right to have guests over, to smoke, to do anything that your roommate also has the right to do. So, unless the landlord or unless there's a previous discussion before everyone moves in that no one's going to smoke inside, none of that is going to change. So this question is completely irrelevant too. Right? The correct answer here should be getting an air cleaner for the apartment. Moving back to the dormitory is irrelevant because dorms are very expensive. Why would I tell her to go? I'm not going to pay for the dorm, so I'm not going to tell her to go do something more expensive. Try to find a new home for the dog. Whoa. People love their dogs just like their own kids. That is completely irrelevant. On top of that, she's already had the dog before too, so that's not a new factor. Turn down the thermostat to keep the ambient temperature at 65. If her roommate is the one keeping it really warm, and again, she's had disagreements, she's had arguments with him already, there's no reason for that to be the reason things are going to get better. So that's a pretty silly answer choice too. The correct answer here should be D, okay? But the correct answer here was A, and there's nothing we can do about that. Alright, so crippling depression. That's what NBME does. I think in question number 1 here was where I started writing. Where's the first one? Question 1. Yeah. Let's go to number 1. Oh, this was 50. Yeah, NBME, right? That's what it stands for. Naturally bad at making exams. That's NBME right there. Naturally bad at making exams. They suck. Their questions are stupid. The images they use are irrelevant. And the answer choices they put are things you should have no idea of. Why would you ever know this? This is okay. This one, so a 22-year-old man is brought to the emergency department 30 minutes after he was involved in a motorcycle collision. Physical exam shows dysmetria on the right. Muscle strength is normal. Which of the following labeled structures in the photograph of a brain is the most likely site of injury in this patient? So all this guy has, the only symptoms he has is dysmetria, and that's it. No sensory loss, no loss of coordination of muscle, no attitude changes, none of that. So immediately you know that dysmetria, or you should know that dysmetria is simply a type of ataxia, right, that has an overshoot or undershoot due to a lack of movement coordination. So that should really zero you in to D or E, where you're trying to pick the cerebellum, right, because ataxia is relevant there. And E is clearly the cerebellum, so you would just log that in and you'd be done. Okay. D is also very close and definitely part of the cerebellum in ways as well, but that's not the correct answer. So you can see how this is a cross-section down the middle. So D is basically talking to you about something that's really medial. Okay. The medial part, it could be the flocculonodular lobe of the central medial cerebellum, and that would cause truncal ataxia. Remember that the middle part of the medial part of the cerebellum causes truncal changes. Either side of the cerebellum, whether it be the left or the right side of the cerebellum, those lateral parts actually cause effects in that part of the body, ipsilateral side of the body. So if his right lateral cerebellum got injured from this motorcycle injury, then he would have right dysmetria, and that's fitting. Right? So that's all this question is about. I put these images here because these are actually really high definition compared to this, and very well drawn to point out all the parts of the brain you should know, right? And they're good for review too, like especially this image from, I believe this is the Netter image here, where you can actually look at each thing and get a good idea of what you're supposed to see on gross. Right? So you can compare to this gross image here and have a good idea of what each of these do. So go through all of them for when you're studying and make sure you know what each of these are for. Some of them you might not know what they're about, so go ahead and search it up and learn it. Okay? That's the active part of actually studying. It's a really nice image. It does the job. It also labels all the different parts where CSF is going to flow, so it's very handy. Okay. The other answer choices here are not exactly very clear. For example, A, I can't quite tell if it's the post or pre-central gyrus there, right? Because this fold is coming from under rather than above. You can see how here there's a fold coming from above, right? That gyrus is clearly the paracentral gyrus, and you could tell what's in front and what's behind. Here, it's not exactly evident. I'm not quite sure why, but whatever it might be, our answer was not relevant to this part. Right? Our question was not related to the cerebral cortex, so it's okay if it didn't make sense. B is pointing out the thalamus, right? And that's not relevant for our patient either. Thalamic injuries would have sensory changes for like heat, and our patient didn't have any of those sensory changes, so that was irrelevant. C is pointing at the pons, and that's not relevant to our patient's symptoms either, so that's all that was. 11. A 54-year-old man with an MI becomes progressively hypotensive. Which of the following physiologic events is most likely to cause swelling of the parenchymal cells in his vital organs within minutes? Now, this is a very high topic about the progression of MI. After an MI, the hypoxic environment of that damaged heart leads to use of anaerobic respiration and a deficiency of ATP plus a rise in lactate. The lack of ATP and rise of lactate is similar to what happens in strenuous exercise. So that's a good way to remember it, right? When you're exercising a lot, you run out of oxygen and you get that lactate and it burns and then you stop running or stop doing whatever exercise you're doing. So that's the same thing that's happening in an MI. That excessive exercise of your heart, the stress that is going through in that MI causes a formation of this kind of lifestyle. ATP is running out, lactate is being formed, and you're doing anaerobic respiration. Now, without the ATP, the sodium-potassium ATPase fails, right? It's not going to do its job anymore, so there's an accumulation of potassium outside, and sodium gets stuck inside, right? Remember, it's pumpkin, right? Pump K in. It's supposed to pump potassium into the cell. So it's not going to be doing that anymore. So there's a lot of extracellular potassium, which is what predisposes patients right after an MI to getting a ventricular arrhythmia. Potassium is really sensitive to, the heart is really sensitive to potassium outside of it. At the same time, there's also an intracellular accumulation of sodium and calcium, which actually pulls water in and causes edema. The intracellular calcium also causes hypercontraction of the myofibrils. Okay, so these are all things that are discussed in first aid to some level, and then in my first aid, in my notes, I go a little more in depth with it, and I obviously have UO questions relating it, right? Because that's how I tie things together with the students I tutor. Right, so this is a UO question regarding the same kind of thing about which ions would be high. Here, the correct answer was calcium, right? Intracellular calcium would be high, and that's what's causing the cells to increase in size. And that is true, right? Intracellular sodium and calcium. Of course, they had intracellular potassium as an answer choice too for this UO question, and a lot of people picked it. But the potassium would be extracellular, not intracellular. Right? So that's what happened in the first 24 hours. I go in depth about it right here. Very much worth knowing. And then, of course, the extracellular potassium is what can cause ventricular arrhythmia. Later on, after the 24 hours, within the first 1 to 3 days, there's a chance of post-infarct fibrinous pericarditis, and there's a lot of coagulative necrosis, there's a lot of neutrophils, right? A lot of things happening here. The body is still trying to recover, the heart is still trying to recover, and you start seeing the coagulative necrosis beginning. That's really all you're going to have here, though. This is the easiest part of the evolution of an MI. Days 1 to 3 is just about the coagulative necrosis, neutrophils on histology, and a risk of post-infarctive fibrinous pericarditis. After that, within the first 2 weeks, around that range is when you start putting out granulation tissue, right? And now you can see there's a lot more cellularity here, a lot more cellularity on the histological image that they might provide to you. But with all of that, you're starting to form scar tissue, so you have a risk of free wall rupture. You can get tamponade. You can get a pseudoaneurysm where this kind of stuff happens, okay? And it's still pretty dangerous. There's also risk of mitral regurgitation with the papillary muscle rupture, posterior medial. After that, once the contracted scar is finally done, you now have a part of the heart that's so solid it's not going to beat very well like it used to before. Right? So that's this part right here, and that increases the risk of a mural thrombus. A mural is like a painting, so a thrombus on a wall, right? And that's what you're seeing here, right? So this hypocontractile part is where blood can start clotting up. Okay, so that's why after an MI, there's a lot of things you have to do for treatment purposes, right? You give people all of these medications to keep them from developing all those different results of recovering from an MI. Okay, so very easy stuff. It just takes multiple times of revision, and then of course mastering it means that you should be able to reproduce all of that without the book in front of you. You should be able to write down the days and the things that happen on it, what you would see histologically, and what are the risk factors. All of that without the book in front of you. And that's what the whole full mastery playlist is about. Gaining mastery about things in such a way that you don't need the book anymore. This was a dumb question, but again, it's NBME. It was stupid. The pedigrees of patients with schizophrenia most closely resemble those of patients with which of the following? Okay, schizophrenia is not exactly inheritable per se, but there is some kind of genetic association. But it's not just because of genes. It's also due to habitual things and things that the child might have seen as he was growing up. But there is some genetic association, but there isn't a clear form or there isn't a clear pattern of inheritance for schizophrenia. So you look at all your answer choices and you pick the only one that doesn't have a clear pattern of inheritance, and that would be diabetes DM1. Cystic fibrosis is autosomal recessive. Fragile X, is related to the X chromosome. Polycystic kidney disease could be autosomal recessive or autosomal dominant, depending on which one you're talking about. And then Tay-Sachs is an enzyme deficiency, and that's also got a solid form of inheritance. So none of those answer choices make sense. Again, though, this question is really stupid because it doesn't really test any solid knowledge besides the inheritance patterns of some things. But in all honesty, if we looked at patients' pedigrees with schizophrenia and patients' pedigrees with DM1, I'm pretty sure they would not look the same. DM1 is slightly more genetically related than schizophrenia probably is. I'm sure we would see more family inheritance of DM1 rather than the schizophrenia tree, but who knows? Maybe they're pretty similar. I haven't done the research on that. It's just a stupid question though. So hopefully everyone got that one right, or will get that one right. This was okay. So 62-year-old man comes to the physician for a follow-up exam. 1 month ago, he was prescribed a proton pump inhibitor like omeprazole for epigastric pain that is relieved when he eats. Physical exam shows no abnormalities. The patient says that the medication has only partially relieved his symptoms, and he still has discomfort. Serum studies show a gastrin concentration 4 times the reference range. The physician discontinues the PPI therapy in the patient. 3 weeks later, additional lab studies are ordered. It is most appropriate to measure the concentration of which of the following at this time. So, as a doctor, you're thinking that maybe she has a gastrinoma, right? Because why is her gastrin so high? Is her gastrin so high because the gastrin is not actually getting a result of making acid? It could be that too, right? Gastrin is not working because of the proton pump inhibitor. So if we stop the proton pump inhibitor and the gastrin successfully makes acid, then the gastrin concentration should decrease. So when the patient comes back later, after stopping the PPI, I would just measure the serum gastrin again. There's no reason to measure any of the other things. Okay, there's absolutely no reason. If the gastrin didn't decrease after stopping omeprazole, then she could probably have a gastrinoma or some kind of other issue that's causing her to produce a lot of gastrin. Otherwise, normally when you stop taking PPIs, there should be a transient decrease in gastrin concentration. Okay, so that's just a check on the negative feedback loop. This was a very easy, straightforward question. 59-year-old woman has a 10-year history of progressive right-sided hearing loss. An MRI of the head shows a large cerebellopontine angle mass that has compressed the vestibulocochlear nerve on the right. So they're obviously talking about an acoustic neuroma. You can see from this New World image that an acoustic neuroma can compress many different nerves. Within this triangle, you have your cranial nerve 8 and cranial nerve 5. Okay, so either one can be compressed depending on how big it gets. Then they just want to know the mass most likely arose from which of the following cell types, and it's a neurocrest cell derivative, right? Acoustic schwannoma is a Schwann cell derivative, and Schwann cells are neurocrest cells. They do stain S100 positive, so just neurocrest cell. That's it. This one, 32-year-old woman recently diagnosed with AIDS is at greatest risk for developing which of the following neoplasms? So that would be the Epstein-Barr virus-induced brain lymphoma. The other things can actually occur to pretty much anyone. H. pylori gastric lymphoma, hepatitis B, hepatocellular carcinoma, hormone-induced endometrial carcinoma, hormonal, right? And then ultraviolet light induced skin melanoma. B, C, D, and E can occur to anyone. They don't have to have AIDS for that. But Epstein-Barr induced brain lymphoma is actually one of the AIDS defining illnesses. So you want to make sure you know your AIDS defining illnesses. AIDS is very high yield on step 1 as well. All the different things about AIDS are very high yield on step 1. And you can see here, to get B-cell lymphoma, whether it be the CNS one or the non-Hodgkin one, right, with ring-enhancing lesions, this thing requires a CD4 count below 100, which is definition of AIDS. Okay, so these are all your AIDS defining illnesses over here. Right. Nothing crazy. Again, there were many questions so far in this test where they asked about diagnosing HIV, they asked about the different medications used in HIV. Previous NBMEs have asked questions about HIV-1 versus HIV-2, you know, how they're different and what you're supposed to do about them. So there's a bunch of the questions the NBME can ask about HIV, so you want to really make sure you understand HIV and AIDS and all the different AIDS-defining illnesses pretty well by the time you're ready for NBME. Okay, this one, 28-year-old man has had a blood pressure cuff placed around his left arm. The cuff is inflated to totally occlude arterial blood flow for 2 minutes, and then it's removed. Blood flow in the left arm increases by 50% during the next 3 minutes, and then decreases to control values. Right, which of the following humoral substances is most likely involved? What's allowing something like that to happen? So you look at all your answer choices. If you know all of these hormones very well, then you'd be able to knock out everything and just have adenosine left to pick as your answer choice. None of the other answer choices really have much to do with this concept of a blood pressure cuff, blocking blood flow, and then, you know, when the blood pressure cuff is released, that there's vasodilation. None of the others actually do anything like that. This is about adenosine. And you can see from this image, right, this isn't really discussed in first aid at all. They talk about the medication adenosine, but not the receptors and how it works. So adenosine uses A1 or A2, and these are not alpha 1 or alpha 2, these are A1, A2. Either A1 or A2 receptors, depending on where. In the book, they talk about A1 receptor-related activity, decreased chronotropy or decreased dromotropy if adenosine is given for cardiac purposes, where it'll work at the nodes, SA and AV nodes. The dromotropy is basically a decrease in nodal conduction. Okay, and chronotropy is a decrease in heart rate. So it uses A1 GI to decrease cyclic AMP. In blood vessels, adenosine uses A2 receptors to ramp up GS and make more cyclic AMP to cause vasodilation. Okay, and this is often tested. UWorld asks questions about it. It can be on your step 1. It's definitely worth knowing. Definitely worth knowing. Okay, so this was adenosine. Many NBMEs have also asked questions about this physiology of placing a blood pressure cuff and then releasing it, and how things change, the dynamics of it. Always questioned. So grasp that concept pretty well. This was stupid. This should have been non-nucleoside reverse transcriptase inhibitors, but this is just nucleoside, which is the wrong answer choice. 37-year-old woman with HIV infection is brought to the emergency department because of a 6-hour history of chest and abdominal pain, as well as shortness of breath with exertion. She's currently receiving antiretroviral therapy. Pulse is 100 per minute, respiration is at 20, blood pressure is a little low. Physical exam shows no abnormalities. Lab studies show you all of this. So bicarb is looking a little low, liver enzymes are high, right? Lactate is high, pH is low, and PO2 is 98, so PO2 is fine. Drug from which of the following classes is most likely causing these findings? So whatever is happening is causing hepatotoxicity. As you can see, the liver enzymes are much higher than they should be, right? So which of these drugs cause liver toxicity? So that's what I was saying. There's a lot of questions in this NBME this time around about HIV and HIV therapy. So I revised all of these already in one of the previous videos for the same NBME, because there was another question about HIV therapy. When you're looking for hepatotoxicity, right, that's occurring with this, and in RTIs. In the question, they told you there's no rash, and maybe one of the reasons they said there's no rash, she's currently, where they say it, physical exam shows no abnormalities, right? No abnormalities, there's no rash. So maybe one of the reasons they said that is because that's how you don't pick NNRTIs, but NRTIs are not apparently known to cause hepatotoxicity. It's not in the book. When I looked it up on Wikipedia, I did see that some of them can cause hepatotoxicity, but you know, first aid doesn't have it, and that's all we're supposed to really use for step 1 prep. So it's kind of stupid that it wasn't here. But yes, either way, the other answer choices, all of these guys definitely do not have any hepatotoxicity, so you can knock them all out and you'd be okay. Right? But make sure you have a good general summary of what all the different ones side effects are, because the entry inhibitors only have one thing, which is a little skin reaction with N-fuvertide, but nothing else other than that. Integrase inhibitors simply have an elevation in CK and nothing else other than that. So those are super easy. The protease inhibitors have a bunch of metabolic things that can occur, so you want to make sure you have a good idea of it, because especially the Cushing thing, this can occur, this can show up on the question, and it can be confounding. NNRTIs cause rash and hepatotoxicity, and then F-variance causes sleepiness, right? So you memorize that by calling it F-variance with 3 Z's for sleep. Here, each one has its own little thing, and they're all very unique, so make sure you know this stuff. This is where you have to invest the most time to actually grasp it all. Okay. HIV-1 versus HIV-2 is pretty significant. All ARTs are active against HIV-1 and HIV-2 with the exception of NNRTIs. NNRTIs, I wrote it here. This is also a note from a question that was in another NBME. NNRTIs block HIV-1 reverse transcription through a specific binding site that is not present in HIV-2. This class of drugs will not be effective against HIV-2 due to a Y188L polymorphism. You don't necessarily need to know the specifics, but understand that NNRTIs don't necessarily work against HIV-2. That's all that's about. Okay, 18. No idea why you would know this. Absolutely no idea why you would know this. 32-year-old woman comes to the physician because of pain and swelling of her right cheek for 24 hours. Physical exam shows a mildly swollen and tender area overlying the parotid gland. Silolithiasis is suspected, and that's in the book, silolithiasis. The calculus is most likely present in a duct that passes through which of the following muscles to enter the oral cavity. So simply because they said enter the oral cavity, I went with buccinator, but I had no idea why it would even be the buccinator, but it was. And this image kind of helps. So we're talking in this question about Stenson's parotid gland duct. Right, so this Stenson duct over here actually enters the buccinator, which actually ends up bringing parotid secretions into the oral cavity. No reason you would know this, no reason for you to really care about it, but it is what it is. Okay. Okay, this was alright. So 35-year-old woman with asthma comes to the emergency department because of a 1-week history of abdominal pain and diarrhea. She also has had progressive cough and wheezing that paradoxically worsened shortly after she began treatment with oral prednisone for an asthma exacerbation. She recently returned from a trip to Papua New Guinea. Her temperature is 37.8, so she's got a fever. Pulse is 96 per minute, respiration is at 24, blood pressure is perfectly fine. Physical exam shows cutaneous larva currents, right? Cutaneous larva currents over the abdomen. A chest x-ray shows bilateral central alveolar infiltrates. Leukocyte count is 18,000 with 23% eosinophils. So the eosinophilia is pretty significant for some kind of parasitic issue. Stool exam and analysis of fluid obtained on bronchoalveolar lavage showed the presence of the organism shown in the photomicrograph. So this is the image they gave in the question, the green one. Prednisone is discontinued. Which of the following is the most appropriate pharmacotherapy for this patient? So you could tell there's a worm here, and worms are treated with bendazole, so thiabendazole is what you would pick. This image here is showing you the cutaneous larva currents. That's what it looks like. Right? Cutaneous larva currents. She has strongyloid stercoralis infection. This is all due to strongyloids autoinfection. Remember, strongyloids causes autoinfection. It comes up your throat, and then you inhale it, or not inhale it. You eat it, ingest it. So it comes up, and you ingest it again, and enters yourself over and over again. Okay, so it's a forever kind of worm that's just going to keep infecting you and infecting your lungs. So 164. Let's take a look at it. Right, stercoralis. Right? Autoinfection. Rarely, some larvae may penetrate the intestinal wall to enter the bloodstream without leaving the body. Larvae in soil penetrate the rhabditiform larvae seen in feces under microscope. You could treat it with ivermectin or bendazoles. Excuse me. So the thing here is that the book already mentions cutaneous larva migrans, but the book doesn't mention cutaneous larva currents, so I put it here. Right? Cutaneous larva currents is almost pathognomonic for strongyloid stercoralis, whereas if they ever mention cutaneous larva migrans, this migrating one is in the feet, which makes sense. easy to remember that because you migrate with your feet. This is in the feet because ankylostoma and necator, these guys actually usually break in, right? So, pruritic serpiginous rash from walking barefoot on contaminated beaches. They come into your feet, right? Larvae penetrate the skin. So, strongyloids you didn't even need to diagnose what's actually causing the infection as long as you had an idea of it being a worm, which they showed you, and you would just pick the bendazole. All of these, as you could tell, are pretty much treated with bendazoles, right? So not the hardest thing. You can see how everything pretty much uses bendazoles. The only ones that don't are right here. So carbamazine for Loa Wucheria burcrofti, and if you did sketchy micro, you remember that because the Wucheria witch and the Loa guy here are both reading a magazine. The magazine is for carbamazine. Ivermectin causes river blindness and river ivor, so you can remember ivermectin like that. Okay. Very high yield bug, Onchocerca volvulus, very high yield bug. There was a question about this bug in NBME 24 also, I think block 1 somewhere, so we already did that. So nothing crazy here. Praziquantel is actually appropriate for worm or liver fluke, okay, but not for this stuff. Not for this stuff. So she has a tapeworm in her body, an intestinal parasite, excuse me, in her body. So, you know, at the very least, when you were doing this question, you should have at least come down to D or E, and then you learned now if you got it wrong. Okay. This was a very nice question. Does a good job teaching you more about stuff that you might not feel so comfortable about. The whole concept of shock. Okay. 65-year-old man is brought to the emergency department 30 minutes after the sudden onset of shortness of breath and discomfort in his chest. He says he feels weak and apprehensive. Pulse is 110 per minute, respiration is at 22 per minute, blood pressure is 100 over 80. Physical exam shows diaphoresis. ECG shows ST elevation in the anterior leads. Compared with a healthy man of the same age, which of the following sets of cardiopulmonary changes is most likely in this patient? So usually I find it very easy to start these questions with PCWP because that should be the first thing you should be able to figure out based off of the presentation. For some other people, systemic vascular resistance might make more sense. Either way, one of those two things should be very evident. This patient has cardiogenic shock, possibly due to an MI he's experiencing. And since it's in the anterior leads, it could be a right ventricular MI. Since his heart cannot pump blood well, blood will stay in the heart, and that's going to increase the PCWP. So you can knock out all the answer choices that say otherwise, right? So anywhere that PCWP is decreasing would be wrong. So this would be wrong, that would be wrong, and this would be wrong. So you're really just between B, D, or F, right? You knock out A, C, and E. To fix this PCWP issue, the body will have a sympathetic response, and catecholamines will cause peripheral vasoconstriction. Right? Remember, if you're diaphoresing, if you're sweating, you should think of sympathetic activity, right? Running, like fight or flight type of activity. So sympathetic response will actually cause a rise in peripheral vasoconstriction, rise in blood pressure. So that would knock out D, E, and F. And then you're just left with B from what we already knocked out. So B was the correct answer. You didn't even need to figure out the pulmonary vascular resistance part, which could be very hard for some people. The pulmonary vascular resistance is determined by autoregulation. Since the heart is failing, it may release local vasodilatory metabolites, and that would cause pulmonary vasculature to dilate. Right, so pulmonary vascular resistance would decrease. You would not have pulmonary hypertension in a patient with MI, okay, as a result of the MI. So when you look at shock, you want to make sure you spend enough time to be able to talk about all of them very well. There's a little trick. Usually when the patient presents with shock, they have a low blood pressure, and that's immediately what makes you think of the shock. This low blood pressure does not equate to what's going to happen to this. It's usually the opposite of that. So if their blood pressure is low, they're going to respond by increasing systemic vascular resistance. So that immediately knocks out these three answer choices. Right, so that's another little thing you can start doing once you get more comfortable with shock. Here on this page, you could just pause and look at it whenever you want. In my notes, I've talked about all the different kinds of shocks and what they're about. Right? And the book teaches you what happens with PCWP and systemic vascular resistance, which you can see always increases. The only time it doesn't, it decreases, is if it's a distributive shock. Usually the septic or anaphylactic shock. Right? Those things cause a decrease in blood pressure, a very significant decrease in blood pressure. And all of that is based off of cardiac output times SVR is equal to MAP. Right? Your body's going to try to maintain MAP. So how are you going to maintain that MAP is what this is based off of. Okay. Our guy had a cardiogenic shock, usually because of acute MI or heart failure or anything really. 21 was a question about CGD, chronic granulomatous disease. So a 3-year-old girl has a history of recurrent infections. In vitro, neutrophils isolated from this patient are capable of phagocytosis and can kill lactobacilli, but not Staph aureus. This patient most likely has a defect involving which of the following enzymes? So Staph aureus, how is it different from lactobacillus? Well, one of the key things about Staph aureus is there's a cat in that image, a sketchy micro. It's catalase positive, right? Then this looks like a question about catalase positivity. Because neutrophils are working against one type but not another, something's not working here. So the patient has chronic granulomatous disease. S. aureus is a catalase positive bug, so it is able to convert its own hydrogen peroxide into oxygen and water, right? And let me fix that real quick. Hydrogen peroxide into oxygen and water. Otherwise, patients without NADPH oxidase can still use the bacteria's hydrogen peroxide to create radical oxygen species and kill the bacteria. For this reason, patients with CGD are susceptible to catalase positive infections. So let's take a look at that real quick. Page 117 and 109. Let's see what's happening. Because if you're having a little trouble understanding what that's about, and you want to make sure you spend time here. Right, so normally what's happening is you're going to have H2O2 right here, right? And bacteria that have catalase, any bacteria that has catalase will take the hydrogen peroxide and break it up into water and oxygen. And that sucks, because now you cannot use the H2O2 to actually make HOCl and kill the bacteria. And that's the problem with chronic granulomatous disease. In chronic granulomatous disease, the patients with CGD are supposed to be able to utilize H2O2 to convert it into HOCl and kill bacteria. But catalase positive bugs are able to convert their own hydrogen peroxide into water, thereby getting rid of any ammunition you would have to kill the bacteria. Okay, and that worsens the infection. Okay, there were 2 questions about this stuff right now, and then another one in, I think, 36 or something. So that'll be in the next video. But a 12-year-old boy is brought to the physician by his mother for a well child examination. His mother says that he has outgrown the clothes that she bought for him 6 months ago. He's at the 50th percentile for height and weight. Based on his medical records, the physician estimates that the patient's growth velocity is about 2.3 inches a year. Physical exam shows mild acne over the face. Pubic hair and testes development are tan stage 2. Which of the following is the most likely cause of the onset of physical changes in this patient? So it looks like he's going through puberty. Okay, that's all that's happening here. What's causing it? It's the nocturnal LH pulses, right? First of all, in reproductive, when you study it, you'll see, and even in endocrine, almost all hormones need to be released in a pulsatile manner, in a very weird pulsatile manner that's controlled by your brain. Which is why you can't really take replacements of some of these hormones, because as soon as it's no longer pulsatile, and if it's constant or continuous availability of some of these hormones, that causes the opposite effect of what that hormone would normally do. So this patient is going through puberty simply because of LH, which is going to cause more testosterone, and that's going to cause the acne and the growth in height. That's all it was. Right? You want to make sure you remember this stuff here. This is very significant. LH is for Leydig, and the ladies love testosterone, so Leydig cell makes testosterone. Sertoli cells are your nurse cells. They just help with spermatogenesis. And Sertoli cells also make the inhibin that goes back and gives a negative feedback to anterior pituitary. Very important to remember this entire feedback mechanism of the reproductive hormonal system for both men and women. This is the male one. So that's, nocturnal luteinizing hormone pulses. Okay, this was iconic trash NBME. This picture is exactly how it shows up on your test too. So when you look at this picture, you actually cannot see what they want you to see. A 4-year-old girl has a history of multiple bone fractures and poor wound healing. A photograph of the face is shown. Which of the following components of wound healing is most likely to be affected as a direct result of her underlying disease? Now, if you forgot about the picture in general, any 4-year-old girl with multiple bone fractures and poor wound healing should make you think of osteogenesis imperfecta, at which point you would pick answer choice E and move on. And that's what it is. Believe it or not, this image is trying to show you blue sclerae. Right, so like AUSOMA, I wrote the rumor has it this image was taken with the Nokia, and that's why this image is actually still around even though we have 108 megapixel cameras. Right, Nokias never break, and neither will this image. This image will always last. This image is supposed to show you blue sclerae. I, for one, can even argue that I see white keratin deposition. Right, it was, to me, when I was looking at the image, I was like, what are they really trying to point out at this image? Because this portion here looks really white, and I guess that's telling you that since these are white, those other areas, this is all blue, this is all blue, this is all blue, and that's all blue, you know. But again, like, this is just such a terrible picture to make the point here. Why would you use such a low definition trash image? Scars are made of type 1 collagen, and this is a kid with OI, osteogenesis imperfecta. So that's all this question was. Very doable question, but again, ridiculous image. Why even have an image at that point? 17-year-old girl has significant blood loss after being injured in an automobile collision. Blood loss stimulates bone marrow to synthesize which of the following? So I don't even know why they try creating stories anymore. Like, this is the stupidest little story here. Automobile collision is the easiest thing you could write a story about. They could have just written down blood loss stimulates bone marrow to synthesize which of the following. And that's basically all they want to ask you. So bone marrow doesn't make some of these things. Okay, bone marrow makes one of these or some of them, but not all of them. So because of blood loss, you're going to try to make more blood. And some people might have immediately thought of erythropoietin and picked C, and that would be wrong because bone marrow isn't what makes it. EPO is made by your kidney. Remember, chronic kidney failure leads to a lack of EPO, and patients can present with anemia. So EPO would be wrong in that aspect. This is the correct answer here. A. The D-ALA, delta aminolevulinate, D-ALA, is what your bone marrow is going to start making because that's the first step of heme synthesis. Right? You combine glycine and succinyl-CoA to make the D-ALA, and then you make more hemoglobin. Last question for this video. 1-month-old male newborn is brought to the physician for a routine examination. So that's significant, right? Always remember why someone's brought in. If someone's just coming in for a routine examination, that means something severely bad is not happening. His parents both have olive-colored skin, dark hair, and dark eyes. Physical exam shows hypopigmentation of the skin, light blonde hair, and translucent irises. The inherited disorder, which is clearly albinism, that causes this phenotypic expression is most likely due to a defect in the metabolism of which of the following? Tyrosine. Tyrosinase is the enzyme that's not working in albinism, right? That's straight from biochem. So right here you can see tyrosinase is the enzyme required for making melanin. So albinism has a lack of tyrosinase activity. You don't make melanin and you end up getting albinism, right? Everything was lacking pigmentation. Alright, so that's it for this video. I should be back pretty soon. I'm feeling pretty dry in my mouth, but I'm going to see if I can. Otherwise, I'll finish it tomorrow. And we'll wrap up the last 25 questions of NBME 24, and we'll be done with that playlist. Thank you very much for joining. Keep studying hard, guys, and I'll see you again very soon.